Okay. Uh, okay, perfect. Thank you everyone for tuning in. My name is Amy, and I'm one of the thrombosis fellows at the University of Ottawa in the thrombosis program. And today I have the privilege of monitoring this CAN Vector National Thrombosis Seminar. So the CAN Vector Thrombosis Seminars are a series that is hosted throughout the academic year, and it features state-of-the-art thrombosis and venous thromboembolism lectures presented by both Canadian and international experts. All the seminars are recorded and can be viewed on the CAN Vector website. And as a reminder, the CAN Vector National Thrombosis Seminar is a self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. Before getting started, I'd like to acknowledge and thank the members of the planning committee for their efforts in organizing these seminars. I'd also like to thank Crystal, who's our CAN Vector Research Network manager, for keeping us organized and on track, and as well as Caleb for all the tech and making this go smoothly. So for today's seminar, we are privileged to have the wonderful Dr. Grégoire Legal speak to us about thromboprophylaxis in hospitalized acutely ill older adult medical patients, the symptoms trial. Dr. Legal is a physician and professor in the Division of Hematology in the Department of Medicine at the University of Ottawa. He's also the director of the Thrombosis program in the Division of Hematology at the Ottawa Hospital and a senior scientist with the Ottawa Hospital Research Institute. Dr. Legal was born and raised in France, where he received his MD from the University of Brest in 1997, followed by a PhD in clinical epidemiology from the University of Brest in 2007. He completed his internal medicine residency at the Brest University Hospital in France, followed by an angiology fellowship in Geneva University at the hospital in Switzerland, and then finally a thrombosis fellowship here in Ottawa in 2008. His primary research interests include diagnosis and management of venous thromboembolism, including the clinical diagnosis of VTE and also the derivation and validation of clinical decision rules for VTE. So for today's seminar, we have the objectives listed here. And as a reminder, throughout the seminar, you can submit your questions in the chat box, and there will be a 15-minute Q&A session at the end of the presentations. And so now I'll hand it over to Dr. Legal.
Thank you, Amy. Hi, everyone, and thank you to the organizing committee for inviting me to do this presentation today. We'll discuss again the symptoms trial. Some of you might have heard me presenting that before at the last ISTH meeting in Montreal, but I would present a bit of a deeper dive in the results and also open up to a discussion as to what the next clinical trial should be, or how do you see the field going. So this was the title slide of the initial presentation in Montreal, and I was certainly, I was a quote unquote senior author on that paper, but truly the initiative of the study and the conduct of the study as well is a fact of my former mentor and in Brest, Professor Dominique Mottier, for the ones who don't know him, and he just retired, but has been the lead of the thrombo program over there for many years and a very successful clinician scientist as well. These are my disclosures for today's presentation. And just quickly going back to the learning objectives, which we presented already. So again, briefly presenting rational design results of symptoms, discuss some of the challenges that we faced, and brainstorm on what the next study should be. So before I start, and it's important, I think, to remember that when we discuss thromboprophylaxis, because sometimes the data is a bit disappointing and we're like, why are we doing that? Or should we still be doing that? And I think the an important fact to remember is that, if we want to reduce the global burden of VTE, certainly one of our main targets or one of our main way to reach that should be, I still believe that should be prevention in admitted patients to hospital. So why am I saying that? We'll show you some epidemiological data that we gathered when I was in Brest, Brittany, France. But actually, there are other similar data around the world. They all show the same. So I was working in Brest, which is here at the tip of the nose of France. And as you can see, it was a perfect place to do epidemiology because patients couldn't escape to go to the UK or to Spain or to Canada or New York to get tested or treated for their VTE, so they had to stay there. So we were able to collect exhaustively all the cases of VTE during a certain period of time, and we just had to check with surrounded districts or counties whether they had patients from our area, but this allowed us to capture really the whole breadth of the disease. And I took part in some repeated studies. The last one was led by Aurélien Deluc, where during census years, we would collect all the VTE cases and being able to report on the actual, age and sex incidence of VTE. And so that's one of the particular exercises that we did. I think it was in 2006, where we had 458 VTE cases over the year, typical distribution of patients with DVTs versus isolated PEs or combined PE and DVT. But what was very interesting is that in that particular year, we asked patients where they were at the time of their VTE diagnosis. And as you can see, obviously, the vast majority of patients were outpatient at the time of diagnosis, but we had also a few inpatients, a few patients coming from long-term care. And if you asked patients, the outpatients, whether they had been admitted within the last 3 months prior to the episode, 92 of the 344 patients said yes to that. So altogether, even excluding the long-term care patients, a total of 1/3 of all the VTEs that we would see during that year in Brest were somehow related to a hospital stay. So again, we obviously have many of these unprovoked VTE, and sometimes we feel that it's hard to reduce the burden of VTE due to that fact. But if we want to do that, truly, I believe that targeting hospitalized patients is a way to go. And so that what led to VTE being quoted as being the silent killer in hospitals after all studies showed that PE was diagnosed in 15% of patients dying in hospital, but also very interestingly, that in 90% of cases, the diagnosis had not been suspected prior to the patient dying from the PE. So either death was the first manifestation and there weren't any preceding symptoms, or they were missed, or they were misconstrued, and the patient ended having a fatal PE. But certainly the conclusion from that is that if in 90% of cases death is the first thing that we recognize, then we should certainly prevent rather than let that happen, because it sounds that we don't have always much of a chance of getting through the diagnosis and treatment to prevent bad outcomes. And again, some other epidemiological studies that I won't detail report even higher rates of VTEs that would be related to hospital stays. So how do we do that? How do we prevent clots? Well, for the last 20 years or so, and following publication of the Benelux trial, that was in 1999, low molecular weight heparins have been the cornerstone of prevention of VTE. And I show you here the results of the 3 main clinical trials published back then, in the early 2000s, and showing a clear reduction in the risk of VTE with a very minor, if any, increase in the risk of major bleeding. So when you look at this data, you could say, oh, overwhelming evidence that there was a huge reduction in the risk and we should use it. We'll come back to that, but the main limitation of these trials is that most of these VTE events at day 14 were actually asymptomatic DVTs detected by screening ultrasound. And the risk of symptomatic events was much lower. But following the result of these data, the guidelines strongly endorsed using thromboprophylaxis in medical patients. That's the ACCP 2008 1A recommendation. We recommend thromboprophylaxis with LOMO or FONDA in acutely ill medical patients with certain conditions. And a few years later, actually without many more studies being published, the ACCP again had a much more cautious recommendation, so to speak, saying if patients are at increased risk of thrombosis, then we recommend, but that was a 1B, and if they were either low risk of thrombosis or high risk of bleeding, recommendation was not to use thromboprophylaxis. So again, what changed or what was the reason for that? Not that much that there was a study showing something different, but more that the panel decided to focus on patient important outcome or patient who want the most relevant outcomes, and so decided to exclude from the risk-benefit assessment these asymptomatic screening detected DVTs. And so this was a systematic review that was used to populate the 2012 guidelines. And when you see the result, you do see a reduction in not only in the risk of asymptomatic or total VT events, but also in the risk of symptomatic VTE, without a significant increase in the risk of major bleeding, without an impact on mortality, which is also something that is being discussed a lot when we discuss these things. Just because so far we don't have a clinical trial that would show a reduction in the risk of mortality when using thromboprophylaxis in medical patients. But this is just to show you what the ACCP 2012 panel did with the result of this review, which was again to focus on symptomatic DVT, looking at low risk and high risk patients, and looking also at absolute risks, not only at relative risk, and then showing that, for example, in these patients, you have a risk of major bleedings that would be 4 in 1,000. If you add the intervention, you increase that by 1. If you look at the risk of symptomatic DVT, I didn't do PE here, I just took the numbers for DVT for the sake of the discussion, and having a much and if we were able to discriminate these low risk versus high risk patients, then the risk reduction in the high risk patient would clearly deserve taking the risk of the intervention, while that might not be the case in lower risk patients. So that's where we stand. And so that's the endorsed studies. That was a transversal one-day study in many hospitals around the world, looking at all the admitted patients and looking at how many of them were deemed to be high or low risk of VTE, and among the high risk, how many were actually receiving thromboprophylaxis. And as you can see, that was even before the change in the guidelines, and overall, on average, 50% of admitted patients were deemed to be high risk, and 50% of these high risk patients were actually receiving thromboprophylaxis. And as you can see, there is a huge variations around the world, not that much in terms of the proportion of high-risk patients, but certainly in terms of the proportion of patients who are treated with thromboprophylaxis during their hospital stay. If you focus on medical patients, proportion of high risk is a bit lower, 40%, and of them, 40% were receiving thromboprophylaxis. So I guess why is that? Why are only 40% of patients receiving thromboprophylaxis when you feel that they are high risk, or why is it that we struggle still till to this day in terms of who to start on? I think one of the main reasons is that we don't have in the surgical world. Certainly, the surgical intervention itself plays a much greater role in the decision of initiating thromboprophylaxis or not, even if we do take into consideration some patients-related factors or some other factors. But definitely, the fact of having the surgical intervention is already a very strong indication of what should be done. And we certainly don't have the same in medical patients. They're much more heterogeneous in terms of who they are, their own risk factors, why are they coming to the hospital, for how long, the immobilization levels, and so on and so on. How long did it take them to come to hospital, etc. So it has been, and when you see all these, and I didn't even list them all, but you have many risk assessment models that were proposed through the years. And I think the only fact that we have that many shows that none of them has been really satisfactory for us to use, or has been really easy to use, easy to implement, easy to remember maybe, and would have demonstrated that it has an impact for clinical care. And so why is that? Well, again, I think it's just due to the nature of the patient population that we're dealing with, right? There's so much, like, I don't know, if you think of IBD or you know, infections, the levels of severities that go with that, it's certainly not easy to summarize that through a few items or checklists that you would tick in a score or risk assessment model to make the best decision. And also another big limitation of all these scoring systems is that they were actually all derived in an era where we were widely using low molecular weight heparin. So that became a big confounding factors, because in all of these studies, many patients were actually receiving low molecular weight heparin. So you're not really able to predict who is at risk, because like the patients who were implicitly or using some existing tools deemed to be high risk of VT were receiving low molecular weight heparin in these studies. So just to show you a few of the ones that are maybe the more popular ones. So that's a nice guidelines, but you know, pretty maybe complex to use, or you know, do we do all the GIM and other colleagues involved in the care of this patient have time to go through such an extensive checklist for each and every patient that they admit? Not sure. This is a Padua score, which was the one that was not endorsed, but at least used by the ACCP guidelines, mostly based on this study where, as you can see, patients who were deemed to be low risk per the score did have a indeed low risk of having a VTE, and among the ones felt to be high risk, the ones without prophylaxis had a much higher risk of getting a VTE than the ones who were receiving thromboprophylaxis. Please note the scale here of the y-axis, but again, with the same limitation that this was not a randomized trial, this was observational, so there was some selection of patients to receiving or not receiving thromboprophylaxis here. The other one that gained a lot of traction has been the improved clinical decision rule, derived from a large study of in-hospital medical patients. These are risks of symptomatic outcomes. And as you can see, certainly a bit simpler. Some people don't like the fact that you have an ICU, CCU stay here as a predictor, because it seems like a bit of a different population, maybe. You know, known thrombophilia is always something that's debated as well and carries a, because, you know, does it imply that then you should be tested, or does it imply why were you tested, and so on. But still, some certainly good discrimination by this scoring system. Again, note that age was one of the risk factors there as well. So if we say we're not good at doing it, how can we do to make it better? And some studies have looked at how to implement these strategies, or how to implement better tools for thromboprophylaxis in medical patients. This is a Cochrane database systematic review by Susan Kahn and colleagues, showing interestingly that well, the best data we had was for the use of alerts, which could be electronic, like a pop-up window in your EMR, or even maybe better human alerts, where during the time of study, a nurse or a pharmacist would be in charge of doing the screening of these patients and advising the physicians, or implementing thromboprophylaxis in high-risk patients. Multifaceted intervention were tested as well. Less good results, maybe not enough data. As you can see, for some outcomes, the studies could not be pooled because there weren't enough data there. But overall, when you do that, the alert at least did show a reduction in the risk of VT at the expense, so to speak, of a greater use of thromboprophylaxis, but also of a greater use of appropriate thromboprophylaxis use, because we've seen certainly studies where such a implementation strategy would lead to increase in the use of low molecular weight heparin, but including in patients in whom there was no indication, or patients who were felt to be low risk of VTE, for example. So that's a bit where we were when we started discussing the symptoms trial, and quick reminder that was already in the 2013, 2014 that we started doing that. So we were still certainly concerned by the fact that admission to hospital continued to account for a large proportion of all the VTE cases that we see. That we did have this landmark trial showing a benefit of low molecular weight heparin, but with most of the reduction observed being on asymptomatic events. And I think an important point to make is that certainly there was that downgrade in the guidelines after the decision was made to base a risk-benefit balance on clinically important symptomatic outcomes only. But the issue was that in these trials that were used in the systematic review that I showed you, the one by Dentali, these were the trials where a patient had a systematic screening ultrasound at the end of the treatment. And obviously, if an asymptomatic DVT was detected, most of these patients were started on anticoagulant therapy at that time, at the time of the screening ultrasound. So that kind of prevented the natural history of the disease, or halted the natural history of the disease. So even if at the end the risk-benefit balance was based on symptomatic outcomes, maybe the data was skewed or biased by the fact that a significant chunk, like 15% of Medinox patients in the placebo arm, for example, were diagnosed with an asymptomatic distal DVT by screening ultrasound. And if they were all treated by anticoagulants, how many more symptomatic VTEs would we have seen should these patients not have been screened and not have been started on anticoagulant therapy? Also, I said, I think from these old data, even if you extract the rate of symptomatic events, this rate of symptomatic event is not an actual rate because you had a selection of some patients in these studies who were started on anticoagulation after being diagnosed with an asymptomatic VTE, if that makes sense. So that was really one of the main reasons, and actually the title of the study were like, we need to redo a study in which symptomatic VTE would be the primary outcome, so that the actual natural history of the disease is not altered by the use of treatment in asymptomatic screened detected VTE, if that makes sense. So again, that was really one of the key point of why doing the study, was that we wanted a clinical trial that would be based only on symptomatic outcomes. And the reminders of this, that didn't exist before. None of the ones we had were doing that. Also, to maybe try to solve this problem of the clinical decision rules and the complexity of these patients, and you needed to combine, with the most recent studies, you needed to combine age and the D-dimer and the mobility level and the expected duration of stay or expected duration of immobilization, which is actually quite hard to predict in a medical patient. We thought, well, instead of doing that, let's first try to take all the patients, regardless of their admission diagnosis, regardless of their additional risk factors, but focus on all the other patients, because we knew from previous studies that they were clearly the ones that were at a higher risk of disease, the one with a higher case fatality rate of VTE when they do develop a VTE, and also for some subgroup analysis of these older studies that were maybe the ones with a greater chance of benefiting from an intervention with low molecular weight heparin. So that formed a base for the symptoms trial. So a double-blind, placebo-controlled RCT, centralized web-based randomization, enoxaparin 40 milligram daily, like really the basic thromboprophylaxis versus placebo for a duration of 6 to 14 days. So really mimicking the regimen from the Medinox study, but again, with the main difference of patient population and use of symptomatic outcomes. Initially, we had applied to get a large European funding for this study. That wasn't accepted. We ended running the study in France and Switzerland. DSMB, independent adjudication of event, and the study was sponsored by the hospital in Brest. And as you can see, funding was from 10 years ago now. So who was the patient? Patient age more than 70. Initially, we even had it at more than 75, but realized that we were losing a lot of patients because of that, and ended deciding for feasibility to step down to 70 years. Admitted to hospital for acute medical illness, no specific diagnosis required. Also because when we were participating in older clinical trials, you would often feel that some patients didn't have that CHF or that ischemic stroke or that qualifying diagnosis, acute infection, but maybe were more being older patients with dementia, failure to cope, unspecified diagnosis with, I don't know, losing weight or fatigued, but without a specific diagnosis that would make them eligible for these studies, yet they were felt to be high risk because of their frailty and other risk factors. We wanted them at least to have an expected duration of stay of 4 days, so trying to keep it short so that it would still be predictable, but trying to not have the ones that would certainly be there for a short admission for whatever reason. Exclusion criteria were really aimed at being pragmatic and mimicking the contraindication from the product monograph for the enoxaprine, so previous hit, low platelets, already on anticoagulants, obviously, actually bleeding or very high risk of bleeding, concomitant use of high doses of aspirin or clopidogrel, severe renal failure, unable or unwilling to provide consent. And we didn't take the ICU patients either. So the outcome, the primary outcome was a symptomatic confirmed VT, which could be distal or proximal DVT and or non-fatal or fatal PE at 30 days. And we had some secondary efficacy outcome, which was the same at 90 days. We also collected atherothrombotic events and all-cause mortality. And in terms of safety, the primary safety outcome was a risk of major bleeding as per the HTH definition at 30 days. And other outcomes included major bleeding at 90 days, clinically relevant non-major bleeding, 30 at 90, and so on, as well as fatal bleeding. So in terms of statistics and sample size, obviously intention to treat analysis, time to event, competing risk. We did do cumulative incidences and 95% confidence interval, but as you will see on the results, assumption of proportionality was not met. So we ended providing differences between estimated cumulative incidence rate rather than providing typical relative risk, for example. There were two pre-specified subgroup analyses based on the randomization strata, one of them on the creatinine clearance and the other one on the concomitant use of antiplatelet therapy. This was an event-driven study. Superiority of LOMO versus placebo was a hypothesis. And initially, the initial assumption was a 2% event rate in the placebo arm, and we needed to observe 70 events to get an 80% power to demonstrate a 50% reduction in the enoxaprine arm with a type 1 error of 5%. And so these 70 events based on this 2% rate and so on led to a total estimated sample size of over 4,600 patients. But eventually, during the conduct of the study, we had an issue, I will come back to that, with the expiration of our study drugs, and we were not able to renew or to get further supply. So we had to stop the study after a bit more than half of the total sample size were enrolled. So we ended randomizing 2,559 patients, half and half, obviously. Some patients who eventually their data could not be used for legal reasons. These were mostly patients who initially consented, but then we realized that they weren't legally able to consent because they were under curatorship, or for example. And as you can see, some patients, a significant chunk and I will come back to that as well, in between the intention to treat and the per protocol populations, the main difference was that a few did not receive the study drug at all, but also maybe a good proportion, like 14-15% in each arm, who received less than the minimally expected 6 days duration of treatment. Some of them were in each arm were also started on full dose anticoagulation, say they were diagnosed with AFib during their stay or something like that. These are the general characteristics of the population. So as you can see, truly old patients like 80 years of age or more, BMI is here, renal function is here. There are risk factors for VT, so a few with previous VT, 6% with cancer, and then the most common admission diagnosis are here. And as you can see, infectious disease was number one, but then we had all these patients who were coming with after having had a malaise or being found to be confused or loss of consciousness, things like that. And then other more typical diagnoses such as blood failure, general health deterioration, rheumatic disease, and so on and so on. Mobility on admission. So one of the challenges with that is that we don't have a good definition of what's immobility, right? So we use our own based on, not only based on what they were able to do, but also on how did that relate to what they were able to do when they were home. So say if someone was already just moving from bed to chair at home, we would consider like the immobility if they were only bedridden now and not even able to get out. We can come back to that. And then, as you can see, median duration of stay of 8 days and median duration of the study drug of 7 days. Important to keep that in mind as well. So this is the main slide, like the primary outcome of the study. And so we were at the expected rate of symptomatic VT in the placebo arm. Remember that we based it on 2%. We had 2.2% of events, but without a significant reduction in the incidence when using enoxaparin. So as you can see, 0.4% absolute reduction in the incidence, but with a 95% confidence interval crossing zero, compatible with up to plus 0.7%. No difference in the risk of death. Sorry, what did I do there? Here, yeah, just pointing out the stratified analysis, but I will show you that in a graph form later, so we can skip that for now. Something that was very important, I think, and that we will discuss again as well, was the secondary efficacy outcome of symptomatic VT at 90 days. As you can see, we're up to 3% now in the placebo arm versus 2% in the enoxaparin arm. And this was an absolute 1% risk difference in the incidence. And that one was only statistically significant. And what was interesting about that is when you look at the difference in between the outcomes at 30 days and the outcome at 90 days, well, at 90 days, almost all of the additional event outcomes that we had were actually symptomatic PEs that did require admission to hospital again. So something to keep in mind is that these were like the 90 days event were mostly PEs and again requiring admission. So this is a survival curve, unfocused and focused on the low rates here, showing again no statistical difference. And that's what I was commenting early about the fact that the proportionality condition wasn't met with, for whatever reason, almost like a higher rate of events in the enox arm, but then the curve cross and stabilize this way later on. So likely chance finding, I don't know. But see again the 90 days curved here. So obviously secondary outcomes, so only hypothesis generating. But what's really interesting to me is to see how, even if the average, like the median duration of treatment was here, right, 7 to 8 days, you can see how patients in the enox arm tended to plateau, while the ones on the placebo arm continued to experience events. Again, all these delta being symptomatic PEs and reaching that 1% absolute difference in the incidence after 3 months of the initial admission. These are the safety outcomes, and very reassuringly, no difference whatsoever in terms of risk of major bleeding, no difference in terms of the risk of clinically relevant non-major bleeding. And interestingly as well, when you look at, say, patients with a low creatinine clearance or patients taking aspirin, there was no difference in the risk of bleeding, including in patients who were taking aspirin on the top of their enoxaparin. So in terms of a summary of the results, so no superiority of the enox versus placebo for the primary efficacy outcome of symptomatic events at 30 days among older adult patients admitted for an acute medical illness. The study being underpowered due to the early discontinuation after we had these drug supply issues, and in terms of safety, no increase in the risk of bleeding. So these are the stratified analyses that I just wanted to show in greater detail, because I think from clinical practice, it's quite relevant, right? And as a matter of fact, we had half of our patients almost in the trial who are also receiving aspirin during the course of the study. And as you can see, in terms of safety first, maybe aspirin is here at the bottom, really no difference whatsoever, right? The ones taking aspirin, maybe 1% absolute risk of major bleeding, same than the ones not taking the aspirin, and that was in the placebo arm. And as you can see in the enox arm, numbers were really, really similar. So I think that's interesting to keep in mind, kind of thing. And the same in terms of safety for the creatinine clearance, where people who had a clearance of less than 50 milliliter per minute did not seem to experience a much higher risk of VTE, and certainly that wasn't made worse by being on enoxaparin. In terms of efficacy, subgroup analysis, hypothesis generation only again, but what was maybe interesting to me was that for the antiplatelets, you can see how the risk of VTE was again roughly 2% in the placebo arm, unchanged in the one not taking aspirin, but with that trend towards less events in patients concomitantly taking enoxaparin with their enoxaparin. But again, these are subgroups and slicing and dicing of the data. So strength limitation of the trial. Well, certainly starting with the main limitation was a premature discontinuation. So you can say, well, you only got 2,500 of the 4,600 patients that you wanted. In terms of events, so it was an event-driven study, and we needed to observe 70 events to get our statistical powers, and we got 49. So I think in all fairness, we did include more than well, you could see it as a positive point or a negative point, but I don't think everything is explained by low power, because we did have quite a good proportion of our number of expected events. Certainly a very challenging study to conduct, more than what we had anticipated on several aspects, but maybe highlighting here the challenge of enrolling older adult patients with the patients who had some variable degree of diagnosed or undiagnosed cognitive impairment. Certainly some effect where the relatives, like sons and daughters, were very reluctant to have their parents randomized into a clinical trial. A bit of that protective feeling of even in patients who were otherwise able to consent and willing to do it. But certainly that was we were always leaving people a couple of days to make a decision, but we've had certainly a number of patients where initially they were keen on doing it, but then something happened and they wouldn't be willing to consent anymore. And certainly a big chunk of our patients screened being already on anticoagulants for AFib, you know how prevalent that is. And something, again, which maybe, well, we had anticipated it, and we had said the protocol was specifying that if someone was to be discharged before day 6, that we could give them a supply of low molecular weight heparin to finish the 6 days of of low molecular weight heparin at home. But for whatever reason, this did not happen in many, many cases. Either the patients were not willing to inject, or the physicians even were not like insisting on the patient doing that, or finding a way. Well, in France, a lot of people would self-injection is not as widespread as here in Canada. So if you wanted to do that, you had to maybe prescribe for a nurse to go at home to do it and so on. So I guess logistical challenges made that in many cases that wasn't done. In terms of strength, I strongly believe that the focus on symptomatic outcome is an important one. And also the fact that we weren't restricting on very complex combination of patient and disease-related factors. The placebo challenge, so that was certainly a, obviously a lesson learned, but I don't know how we could do differently. But initially we approached Sanofi, who is the maker of the Lovenox. They weren't interested in supporting the trial. We ended contracting with a manufacturer who was actually producing the Lovenox syringes for Sanofi, and they accepted to sell some product as well as the placebo syringes. But the last batch that we received had an expiry date of October 2020, and by then the manufacturer was not willing to renew the contract and keep producing some syringes for us. Obviously, pandemics had arose, and very early on, a very huge increase in the demand for low molecular weight heparin. So we couldn't find anyone willing to stop the production of low molecular weight heparin to produce some placebo syringes for us. So whether that was Sanofi or the other manufacturer of generic enoxaparin, we couldn't secure any supply anymore. So obviously that was a discussion as to whether we should have converted to an open label study, but it's placebo controlled, suspicion bias is high, and we knew that many of these patients might have an asymptomatic DVT. So obviously, if you know that you're in the placebo arm, and you tend to over-suspect, there is a high chance of you finding specifically an asymptomatic DVT in the placebo arm more than in the. So we knew that it was an actual threat to the quality of the data. So preference was made to just discontinue the study over converting it to an open label. So that was a conclusion slide of the study when I presented in Montreal. So no reduction under power, but some secondary finding encouraging the conduct of future studies. And in the last couple of minutes, that's what I want to do with you, and pick your brain on what that future study could look like. And if we were to do a symptoms too, what would you keep? What would you do differently? And what should be the next step? Let you a minute to think about that. So I guess some few thoughts prior to having the discussion, I don't have a design so far. So if anyone is interested, please reach out, because I'm happy to get your thoughts on that and to build a study together. But so certainly, which patients would you test next time? So I liked our focus on older patients. It was challenging, but you can see that despite restriction of no restriction on mobility, no restriction on admission diagnosis, no D-dimer, we did have an event rate of 2%, which was kind of expected and kind of high, 3% risk at 3 months. So, should we do that? Should we go for risk stratification? Something that I like, which we will be doing, is that so now we have a unique opportunity, because we have that placebo arm in whom so nobody got low molecular weight heparin. So we will have a truly good population to be able to either externally validate the existing risk assessment models, or to derive another one if these don't work well, or if we can find a better one. But I think that's one of the silver lining of that study as well. But certainly, when you look at the overall picture and the curves and the rates, you still want, I think, to do some risk stratification, and to likely we need to de-escalate in some low-risk patients. I don't know if Tony Wan and the team from Vancouver are around today, but they have this very interesting project, quality initiative project, where it's a lot of de-escalation or de-prescription in the very low risk patient, and showing that it doesn't really alter safety. And I think maybe part of the next trial should be something like that if we go for an implementation study. Which intervention? So that's something very important as well. Should we have a minimal duration? We said 6 to 14 days because that's what Medinox had. And back then it was easy because anyway, nobody was leaving hospital for a week or more, right? But we now have much more shorter duration of stay. As you can see, 25% of our patients would stay less than 6 days in hospital. And when you look at that in terms of subgroup analysis, the duration of stay didn't have that much of an impact, but certainly it sounds that the duration of treatment might have one, right? And that we had a bunch, again, 200 and more patients in each arm who got less than 6 days of treatment during the course of the study. And these did not derive any benefit from being on low molecular weight heparin. When, if you look at the ones who did get 6 days or more, then you see a reduction in the risk in the incidence of 1%. That was, again, well, secondary analysis, hypothesis generation, but that which the upper limit of the 95% confidence interval was 0. And as you can see, striking absolute risk reduction. So certainly, if I was to do a study again, I would make sure that no patient gets less than 6 days unless they bleed, obviously, or unless there's a reason to stop before. And actually, that's something that the UK guidelines, the NICE guidelines say. All the guidelines recommend against extended thromboprophylaxis in medical patients, but the NICE guidelines make a specific comment as to if a patient is discharged before 7 days, consider extended at least up to 7 days to reach that minimal duration, and certainly I was interested to see that. So would you go again for a low molecular weight heparin? Why not a DOAC, right? And maybe we were a bit fast in saying no role for DOAC in medical patients. Remember the story, right? These are the two large APEX and RAVE clinical trials in medical patients. They tried to kill two birds with one stone, right? Because the two studies were inpatient limited duration of LOMO versus extended 1 month duration of the DOACs. And overall, they were rather negative because of increased risk of bleeding at 1 month and so on. But when you look at what happened during the inpatient stay, the ADOPT study with apixaban did not reach their non-inferiority margin. But when you look at the absolute risks of VTE, it's not the end of the world either, right? I feel they were maybe a bit unlucky, or so the 95% confidence interval of that difference reached their delta of non-inferiority, but it's not as if the rate of VTE was much higher on APEX versus low molecular weight heparin. In the REEF study, rates were similar and non-inferiority was achieved, but there was a significant increase in the risk of major bleeding. As you can see, likely, well, some differences maybe in adjudication processes, or maybe a higher risk profile population in the REEF studies. So they're not approved in most countries, right? They're approved in the US, like the REEF is. We used to say we kill 1 billion pigs every year around the world, right, to produce low molecular weight heparin. And these days it's mostly for the prevention in admitted patients. And so maybe it's time to go back to that drawing board and revisit these studies, which are 10 years old, and try to see if we can test something like that again. Some limitation of doing that, I acknowledge that, sometimes admitted patients, might require invasive procedures. So comfort level with holding LOMO to enable that certainly higher than holding DOACs for a few hours and doing something invasive. But maybe there is still some discussions there. Which timing for the primary outcome? Well, that was interesting as well to me, right? The fact that certainly it seems that there is kind of a legacy effect, right? Because the duration of treatment is here again. But when you've been treated, it sounds that your risk plateaus after a while if you were in the placebo arm, you continue to experience these events. So as if, these distal asymptomatic DVTs that you prevented here do not evolve towards becoming symptomatic events if you have been received thromboprophylaxis, while they might at a higher rate if you were in the placebo arm. So certainly, I think, and also without the main concern of trying to reduce the global burden and so on, maybe having a lens at 3 months instead of limiting the investigation to a month might be relevant. Not to say that we need to extend thromboprophylaxis. Again, the clinical trials have had a hard time doing that, maybe again around finding the best patients to do that. So which study design? I guess we could do a classical RCT, but do we feel that there was still enough equipoise for a placebo-controlled study if we were to target a new population? Or is it more about doing a DOAC versus LOMO in a high-risk population? Although that's a bit similar to what was already done in the adopted Magellan study. Or is it more about doing a cluster trial of a strategy implementation by which we would not stop giving thromboprophylaxis to the lower risk patients and keep doing that for that minimal duration of treatment again, and based on symptomatic events in the ones who are at high risk. So with that, I will stop there. And again, remind the main conclusion from the studies. And I know it's not the best forum today because I'm the only one visible and the only one we can hear, but certainly interested in brainstorming with whoever is interested about what should be the next study. So please reach out, and happy to take any questions. And while people start talking, just acknowledging all the many investigators in the symptoms trials that made it possible and made it us able to get this data today. All right, Amy, yours.
Yes. Okay, so we do have a few questions in the chat. So the first one is from Dr. Susan Khan. Thank you for doing this important study, Gidegwab. How do you think the trial results will inform recommendations in the next version of the prophylaxis guidelines?
I don't know, you are the guidelines person, Suzanne. What do you make out of it? I guess sorry, I should stop sharing my screen, maybe. Yes. Did I do that? Yes. Not sure it will change much. Like certainly, because likely if you say, well, then all the patients are high-risk patients and recommendations stand true. I don't think I would, it's often a question, right, that people ask, oh, then do you think we should stop giving thromboprophylaxis to other patients? And my answer to that is clearly, it was an underpowered study. So, and we have that non-significant, but that absolute difference between risk, particularly at 3 months, particularly PEs. So for now, it's certainly not throw the baby with the bath water and maybe wait until we get more data. But I don't think I would change practice based on that study.
And so our next question is from Dr. Deduc. He says, provocative question. In diagnostic studies, we are comfortable with a 90-day failure rate of 3%. In symptoms, the 90-day failure rate of the placebo was also 3%, including distal DVTs. Do we really need to prevent VTE in medical patients? I know there's a huge difference in numbers of patients between failure to diagnose VTE and a failure to prevent VTE, but still.
Yeah, well, it's an interesting, thank you, Aurélien. I think it's an interesting comment. I think maybe the main difference is that you say 3% for both. In diagnostic studies, the upper limit of the 95% confidence interval around the risk of VTE at 90 days was, up to 3% was felt to be okay. I must say it tends to be less these days, right? Because this was based on a high pretest. And when you look at the rate of VTE in our study here, the 3% is the absolute risk. So the upper limit of the 95% confidence is certainly much higher. And these were all P's as well. So yeah, I think I would, It's a good point, but likely we are above that rate.
All right, so our next question is from Dr. Jim Duquetis. He has his hand raised, and I think he's able to speak as per our technical panel. So let's see.
Are you able to unmute, Jim? Maybe not then?
I think I just made him a panelist, so he might be having to join back in. So just maybe we'll go back to his question when he joins on.
Okay.
Sounds good. So the next question is from Ryan Kersner. Thank you for the excellent talk. One discussion we have often is surrounding duration, but in the context of medical patients who remain in hospital beyond 2 weeks. Would you recommend continuing thromboprophylaxis in these patients while they remain medically active, even if it's beyond 2 weeks?
Yeah, that's a tougher question because I think below now I'm looking at the data. I think I made my mind that 6 days or 7 days are really important. Should we extend beyond 14 days? In this study, it did happen, and so we left some physicians decided to extend, and we provided more drugs to do that. I think I don't have an answer. We do it case by case often, right? If the patient is still in hospital, why, right? So when you feel that the reason for the clot is still there, or the risk for the clot is still there, then I tend to continue. I think it's a bit different when people then move on to alternate level of care, or rehab, or because that we have some literature, right, that after a few weeks or a few months, even if they're still immobilized, for example, including patients who have, paraplegia or stuff like that, or ischemic stroke with motor sequels, that the risk tend to go down after a while. But I don't know what the threshold is. I think two weeks, if it's someone who is just like waiting, can't go back home and is waiting for a placement somewhere, but has no acute medical illness anymore and is able to ambulate, then fair enough, right? If someone is still infected or inflamed or has other risk factors like cancer, previous VTE, and so on, then I think I would tend to keep going. But I acknowledge it's not a satisfactory answer.
So next question we have Dr. Leslie Ski. Interesting early signal for VTE events in the low molecular weight arm. What do you think? Have you looked at elevated BMI as a possible cause of low molecular weight failure? Low molecular weight heparin, sorry.
Yeah, not yet, but we will. Now, that wouldn't be specific to one arm, right? We should see it in both. Something that was interesting as a trialist maybe is that, sometimes you were like, oh, day 1 or day 2, is that a failure of the treatment, or is that a patient that already came to the hospital with their clot and maybe they weren't unable to prevention anymore? And in none of these trials, we kind of had an exclusion period where you wouldn't count the events during the first 24, 48. It's intention to treat, so they were all taken into account. But it doesn't explain why you would have more if that's true in the NOx arm. But still, it was a bit disturbing to have these very, very early events and feelings that maybe we're diluting a true effect by taking them into account. But how to decide, when we did a study in breast in a few years back where we did an ultrasound on the day of admission to GIM, and 5% of patients on the day of admission already had a distal DVT that was asymptomatic, right? So we know that some patients were sick for several days prior to coming to the hospital, and some have already had the time to develop their VTE even before we see them. Hey, Jim.
Yes, I think we have our connection now.
Thank you very much. It's a very important study, Grégoire, and congratulations to your team. And it's also a very difficult study to do on many fronts, as you know. My question kind of reflects not my personal bias, but just, you know, the concept of duration of anticoagulation. And I wondered, you know, some might argue, well, why didn't you extend prophylaxis beyond the period of hospitalization? If you had done that, those curves might have separated more and you might have gotten a statistically significant result. So, you know, maybe the next trial is a placebo-controlled trial, but extending the duration of anticoagulation. I have mixed feelings about that, but I know there are a number of people around that are advocating for extended prophylaxis. So I just wondered how you might respond to that type of issue. Thank you.
Yeah, thanks. Yeah, I agree with you. It's a bit because again, with that epidemiology thing of seeing all these events, and when you look at these curves, or when you look at all the hospital-acquired VTE, we know that 2/3 or 80% of them are diagnosed after the patient is back home, right? So that gives you the feeling that yes, we should keep going. But the question is, in which patients, right? Because when you look at the Mariner study, which was huge, right? I mean, thousands and thousands of patients, and very hard to find these patients because they had all these severity criteria or risk factors that they needed to be able to be enrolled. And we screened hundreds to find one patient to enroll back in the days. And yet, despite that effort to select high-risk patients, when you look at the absolute risk of VTEs that they had in the study, it was super, super low, right? Most of them were, death in whom PE cannot be ruled out events, so unlikely to be VTEs, in fact. And when you look at just the rate of objectively documented VTE in Mariner, it was like 0.2% versus 0.4% or something like that. So you're like, whoa. So again, I think we're back to so does it mean, and it was based on the IMPROVE, but maybe your predictors when you go home should not be the same as your predictors when you come in. Maybe we should use a different set of predictors, more based on what Ryan was saying earlier, right? How do you identify the ones who beyond 40 days need to stay on? Maybe it's based on how much you healed, how much you're still infected, So I don't know. I agree with you. I feel like you want to go there, but at the same time, the previous attempts have failed because we weren't able to find a population that would have a risk that would be high enough to clearly draw benefit from the intervention. Amy is still there, yeah.
Yeah, that brings us just to time, and I think all the questions have been answered in the chat box. So thank you so much again, Dr. Legal, for this excellent talk. And as a reminder, the recording will be available on the CanVector website. And you have a chance, if you can fill out the evaluation to help us improve future seminars, but also to receive your certificate of attendance for your MOC credit. So with that, I wish you all a great day, and I think we'll see you again in January for our next one.
Thank you, Amy, for the moderation, and thank you all.